Welcome to Oncology for the Inquisitive Mind, the podcast where we unpack the complexities and the cutting-edge science of cancer care. Today, we are incredibly fortunate to be joined by a guest who is pushing the boundaries of what precision radiation can achieve. As our first radiation oncologist on the show, Associate Professor Steven David is a leading radiation oncologist at the Purple Palace, also known as the Peter MacCallum Cancer Centre, specialising in breast and dabbling in some lung cancer. For the Inquisitive Mind listeners out there, Dr. David is a true pioneer in clinical trials, from implementing advanced heart-sparing breath hold techniques for breast cancer patients to utilising high-dose precision saber to target metastatic disease. This man has done it all. Professor David, thank you so much for coming on the show.
Oh, thank you for inviting me. Just returned from ESTRO, which is the major European meeting for radiation oncology. This year was in Stockholm. So, very light at night and a bit cold, but lovely city and learned a lot, caught up with some colleagues and friends, and it was fantastic. So, glad to be back and, give up some of the information I learned.
We're very excited to have you, Stephen. I mean, I think for Josh and I, we're noticing as we progress in our careers that radiation oncology is becoming more and more part of the discussion, an integral part of the discussion. At least that's probably just because we're getting more senior. But we're very excited to hear about some of the pearls from ESTRO. And I think you're going to start with the fast-forward debate on fractionation, because I'll tell you, if there's one thing that my patients complain to me about radiation oncology, it's not necessarily the symptoms or the toxicity, it's the having to front up every day for 3 to 5 weeks. And I think this is looking to ameliorate that. Is that correct?
That's right. And I think, it's often a mystery to non-radiation oncologists, but we're a lot about fractions and doses and getting all those things right. And the British have really, really pioneered a lot of the work on fractionation and how much we can give per day and what the biological effect of that is. And breast radiation after surgery used to be 6 weeks for everyone. And some trials in the 90s brought that down to 3 weeks. And luckily around COVID time, and they went a step further and managed to do it all in a week. Certainly for low risk localized breast cancer patients, they're doing it in 5 fractions. That, became really popular around COVID because everyone could get patients through the department in a week. But the question became, can it be done for everyone in all situations after surgery, or are there some situations where you need to be careful? And the debate centered around one side taking the affirmative that 5 for everything in every situation is the way to go. In other words, doing it in a week. And the negative was we need to be careful. And the debate was saying, can we get to 5 fractions by 2036? They've got now some good data for a lot of patients up to 10 years now, which is actually a long time. So some radiation oncologists will say that's still not enough, but 10 years is a long time, and their data was excellent, really low risks of recurrence, and also very well managed, low toxicities. And clearly, I spent a lot of time talking about the economics. So, saving space on the machines, getting people back to work, getting, other cancers treated. So, and breast cancer is so common. So they came up with some figures and saving the world billions of dollars. They said with modern techniques, we can achieve a lot of that. And the negative side spent time really looking at the cases which weren't well represented in the trial. So these are cases where you might treat very large areas where lymph nodes are involved. Patients with very unfavourable anatomy, so perhaps patients with larger breasts, patients that are smoking, and talking about there were some subtle differences in the trial in terms of edema and scar tissue that favoured the 3-week program rather than the 1-week program. They really focused on that. And the other group said the differences are probably clinically not so relevant. And, in the end, the audience voted. I think at the start of the debate, the vote was heavily in favour of 1 week. And at the end of the debate, I think the numbers were about 60-40, still in favour of 1 week, but the negative side, I suppose, won in that they moved the needle more towards their side. And they said there are some situations where you need to be cautious and don't rush ahead too fast. And, I think luckily in Australia, we're not so much limited with resources. So we don't, I think in the UK, you almost don't get a choice in a lot of situations. You just get told you're getting a week of treatment. In Australia, we're a bit more, we have a bit more choice in that because we certainly have a lot of space on our machines and luckily have the resources to do it. That was where that landed. But I think everyone acknowledged that the fast forward trial, which was about 4,000 patients, was a great achievement and really has certainly made it possible for a lot of patients to go down that path. And that's how we practice today. But yes, I don't think it's quite for everyone yet. And they're doing some new trials looking at some of those other subgroups where they're treating nodes, where they're doing boosts, where they're doing other things to try and also see if that can be done in 5. Because the other point they made was that sometimes it's good to have a few trials and do a meta-analysis before you change practice. The problem with radiation oncology is often funds are an issue, and we do one trial and all we have that debate.
It's interesting because, it's always about choose the right patient, isn't it, Stephen? You've got to choose the right patient for the right outcome. And, I was trying to think of some jokes about radiation oncologists before we came on, and all I sort of had was I'm like, I didn't think anything happened after Marie Curie when they sort of, created or sort of identified, radioactive elements. But I'll figure out something better next time you come on the show. But we might move on. That wasn't a bullseye, Michael. I think that was a terrible segue.
I think that was pretty terrible, Josh. Not your best work. Let's be honest.
We are recording after 8 p.m. and after 8 p.m., as everyone who knows me well knows, I like to be in bed.
Yes.
Look, I think I just think the take-home message though is that we're moving towards doing things in a week, and that's fantastic. It's fantastic.
It's great. It's great for patients. Yeah. It's great for clinicians. It's great for toxicity, as long as the outcomes
and financial toxicity.
Yes,
right.
Yeah, as well,
which is huge. But we'll move on to something that will probably eventually take all of our jobs, which is artificial intelligence, where there was the Archery Trial, which looked at, for, again, those not in the know, this is mostly a medical oncology podcast, but, you have to kind of map things out when you give radiation and you get all these like fancy physics, physics. I remember physics. I used to just daydream a little bit in high school. But can you tell us about this Archery Trial looking at sort of radiation planning assistance and what that might mean for the future?
Yeah. So this was a fantastic trial. And what they did was they, as far as I remember, they set it up in a model out of MD Anderson Cancer Center, is, as you know, one of the major cancer centers in the world. And they developed a model to do everything that we do beyond the consultation. So that's the we call contouring, which is the drawing of the plan, targeting, planning, the design. Everything was to be done by artificial intelligence. And what they did was the patients were treated in the usual way by humans, contouring and planning. At the same time, an artificial intelligence setup was done, and they sent all of the plans for quality assurance to a blinded external body to sort of look at them. And they basically said, if you fail anything, so if an organ's drawn wrongly or a target's wrong, the plan fails. The plan doesn't meet criteria, the whole thing fails. So it was quite a high bar to get through this quality assurance group, which was set up in the United Kingdom. And what they found, they did it on a few cancer types, cervix, prostate, and head and neck. And in the cervix cancer patients, they found the pass rate or acceptability rate was 98%. So of the 243 plans they sent through, 238 passed, which was much, much higher than they thought. The prostate plans were a little bit lower at 87%, but still very high. And the head and neck they haven't reported on. So the basic conclusions were that, firstly, this was the largest prospective AO trial ever done. And with cervix cancer, particularly in low and middle income countries, this provides a massive resource saving of time and energy. And this software can be provided via not-for-profit, the not-for-profit sectors for that to be done. And I suppose that's where I think we're going. I mean, obviously not there yet, and need to be careful of certain cases as always. But this is for some people this is a scary thing. But the way I look at it is that it just makes us more productive. With a tool like this, I can see more patients. I can spend more time doing research. I can do other things, and for the planners and radiation therapists, they can do other things. And there's two ways to look at AI. One is fear, and the other is, with optimism and confidence that it's going to let you do more things, see more patients, be more productive.
It's really interesting, and it's not exactly Skynet just yet. But what I found particularly interesting about this from the slides that you've very kindly sent through, and we will make those available as long as that's okay, Stephen, is that is the choice of tumor in this study, like cervical cancer, prostate cancer, and head and neck. These are anatomically quite busy areas. It's not like they've, say, chosen lung cancer where all the AI needs to pick out is a blob in a black space on the scan. So they're actually stress testing it quite well. I guess the question is, or the assumption from a radonc neophyte like me is the plans, I'm assuming, if they are the same as what a qualified radonc would do, the assumption then is that the treatment delivery, the treatment dosing, and therefore by extension the outcomes are going to be the same. Is that correct?
Yeah, I mean that's that. If those, if they've passed that QA, you'd expect the cure rate to be the same. And these days, we're very careful. The bowel can't get above this, and the tumor must get the treatment dose, and all the different what we call organs at risk, which are the things we don't want to hit, have to get an acceptably low dose, and the thing we do want to hit with the radiation, the cancer, needs to get a high dose. So it met all those bars. And I looked through it all, there were a lot of criteria that they looked at on each plan. So it was pretty rigorous. I look at it in a positive way. Others might not.
Yes.
Might not say, am I going to be out of a job or whatever? But I think you can use AI to turbocharge your productivity. And I think that's the way to think about it sometimes.
And it also reminds me of what's happening in radiology as well, where they're training AI on scans, and occasionally you'll get a little bit of a hallucination, but that's part of the model. I think that the final study you've got for us is a very interesting one for Josh and I, because it involves endocrine therapy and radiotherapy as a component post-surgery for low-risk early-stage breast cancers, which is, a battle that we all fight on a daily basis, is trying to get our patients through the adjuvant aspect of an early breast cancer. So can you talk to us about the Natural Trial?
Yeah. The Natural Trial was a Danish trial, and they do lots of fantastic radiation breast trials. And this was another example of that. And what they did was they got what we would consider low-risk patients. So those over the age of 60 with small hormone receptor positive low-risk breast cancer. And they randomized them essentially to partial breast radiation, so just treating a part of the breast, which is really well tolerated, or not. And as part of the national guidelines the Danes have, endocrine therapy is only recommended for patients' PT1C and or grade 2. So a lot of patients didn't get endocrine or radiation. They're just surgery. So in other words, they were treated naturally. They call that natural. That's sort of, I think, where the trial name came from. And they provided an interim analysis of the results, and just looking across. Essentially what it showed was that the patients that went natural, so had surgery alone, the estimated 5-year recurrence rate was 12%, which is probably a bit high, we would all think. Those that had either endocrine therapy or partial breast radiotherapy had estimated 5-year local recurrence rates of about 3%. So they were pretty similar. And if you took both, for the endocrine and the radiation, you'd look to be even lower than that, under 1%. They sort of set a 4% threshold of acceptability. So they felt that either radiation or partial breast, at least 5 years, seemed to hit that. Doing just surgery was not deemed to be acceptable. And if you did both, you get the best result. But the other thing they commented on was that endocrine therapy adherence is an issue. And I think they quoted about 35% didn't complete their complete course of endocrine therapy. And they categorize that as if you went anything less than 4.5 years, you went 4.5 or less, then you were deemed not to be, adherent. So I think what it says, and there was a study presented a couple of years ago called the Europa trial, which got a lot of traction, which was sort of asking the same question, partial breast versus endocrine, and had similar results where the radiation or the endocrine, seemed to achieve equally effective in terms of local control and survival. But what seems to come out in both trials is the endocrine therapy is probably a little bit more difficult, but it's probably got more side effects, not for all patients, but for some. And partial breast in particular, particularly when it can be given over 5 fractions, which is what we do now, it's quite an easy treatment. So if you're an elderly patient, perhaps with a lot of comorbidities, you have surgery and then 5 fractions of radiation and you call it a day, that's not too tricky. And to have a, local control rate up around 95%, it's not a bad option. Alternatively, if you're someone that's against radiation and want to go down the endocrine therapy route, okay too. I think it just adds, again, more options, particularly for low-risk patients. And yeah, I often say these days the hardest patients that I see as a breast radiation oncologist are the low-risk ones, because there's just so many options. And this is just another way that one can manage that disease.
My question to this, and look, it's fascinating and I agree with every point, and I think the data that I've read is exactly the same when it comes to not completing endocrine therapy, is the follow-up is 5 years, right? And so whilst local recurrence, which is I'm assuming what LR stands for, and partial breast radiotherapy, like I'm great, I could just be a radiation oncologist, Michael, I should just switch now, is, the thing with endocrine therapy, it's also distal recurrences that we look at. And so did they talk at all about, I know you're saying low risk, and like low risk, probably pretty unlikely to metastasize, and there's no lobular in this case, which excludes a number of other sort of factors. But were they confident enough to like, look, this is just not going to come back?
That was an estimated 5 years. It was actually worse than that. This was a 2-year follow-up. So interim results, the Kaplan-Meier curves were the estimates out to 5.
Yeah, okay.
So they did comment on there was no difference in survival as you'd expect at this short follow-up.
Yeah.
So this trial and Europa both need longer follow-up for sure.
Yeah.
I'm sort of talking about, like, if you see a patient in the clinic who's 77, has a 7 millimeter grade 2 luminal cancer, do they really need surgery, radiation, and 5 years of potentially an aromatase inhibitor, how worried are you that they're going to get, bone and liver mets? And I mean, I think this is early and promising and is part of a conversation, but far from definitive. I agree 100%. 100%.
I think in my practice, I'm not sure about you, Josh, but those are exactly the sort of patients, Stephen, where we sort of say, endocrine therapy, you might be one of those 66% of patients who take it and then forget about it. And if you do have side effects, we have a very low threshold to stop. And from that perspective, having this data would, I guess, give us a bit more confidence in that. And it goes along with, things that we use like NHS Predict and some of the older endocrine studies.
And I agree. So the other way I think about it is, I suppose, do the 5 fractions of radiation. That generally is really well tolerated. To partial breast. This trial was 15, but we now do it in 5. Go speak to the medical oncologist, see what they say, maybe try it. If you get through a few months and it's terrible, maybe have a low threshold, which is what you're saying. But at least you've banked the radiation, because you sort of can't come back in 12 months and say, I've tried 3 different tablets and I like the radiation now. And if they take it and there's no side effects, fantastic. And this did show that the ones that did both did the best. But if it's a major problem for you and the side effects are challenging, you probably, there's a reasonable chance you might be fine. And I think that's kind of a nice way to think of things.
Well, you heard it here first. Stephen, actually, to all our listeners, if you loved what Stephen said, give us 5 stars, subscribe, do all that good stuff. He'll come back on the show just for you. Stephen, thank you so much for coming on this late night talk show about ESTRO. We look forward to having you back another time.
A lot of fun, guys. Thanks for having me, and see you around.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.